Welcome to Parent Solution. And today we have here with us Dr. Roberto Olivardia. Welcome.
Oh, thank you for having me.
Dr. Roberto Olivardia is a clinical psychologist, speaker, author, and clinical instructor of psychology at Harvard Medical School. And he has been working as a psychologist since 20 years. So today he is going to talk about bipolar mood disorder in young adults. So, Dr. Roberto, tell us more about bipolar mood disorder. What is bipolar disorder?
So bipolar disorder is a mood disorder that's characterized by depressive episodes and what's called hypomanic or manic episodes. So I can dig a little bit into each of those. So with depressive episodes, you're typically not just talking about someone who's sad, but to be depressed where for at least a week or longer, they have very low mood. They feel very worthless, very bad about themselves. Often have problems with sleeping, either sleeping too little or sleeping too much, eating too little, eating too much, feeling sometimes having suicidal thoughts and suicidal ideation, feeling very fatigued, having a hard time concentrating or thinking, difficulty executing very simple tasks like self-care, like showering and hygiene. And it's something that can really weigh on someone. And a lot of times with depression, I think of depression as not necessarily like feeling sad, although people who are depressed can feel sad, can cry, but it can also express itself in feeling angry a lot and irritable and agitated. And that's especially true for men who are depressed, sometimes don't express it in similar ways as women who are depressed. They might express it more in being like very angry and agitated. But people, when they're depressed, often will say that they feel sometimes just numb, like they feel nothing. Like it's almost like the absence of an emotion. They're just feeling a nothingness, which then if you feel like a nothingness, it's not difficult to imagine why then people would just think, well, then if I'm just existing, I might as well just end my life. And those thoughts can creep in. And sometimes with depression, they could be met with psychotic features where people have delusions and certain hallucinations if their depression gets very, very severe. Now, that's what we see with a major depressive disorder. Now, where it becomes a bipolar disorder is instead of just the low mood, it's coupled with these sort of highs and what we call these manic episodes. So a manic episode would be a period where someone has elevated amounts of energy, and not just the energy like, oh, I feel great today, but almost an uncontrolled energy for days sometimes. And it could either manifest itself in a very elated mood. So they might be like, oh, I'm feeling great, but they're not sleeping. They might be engaging in behavior decisions that are very impulsive and not really rational or like them. So an individual in a manic episode might spend $3,000 where they normally would never spend that amount, of money at at a gambling casino or something, or buy 5 pairs of the same shoes, talk really, really fast. They feel like their mind is racing a lot. Oftentimes it's met with not sleeping at all, sometimes for 3-4 days in a row. And a hypomanic episode is sort of like a more we say minor, but it can still have just as significant of an impact on one's well-being. It's just that instead of like a 5-day stretch, it could be, a couple days. And mania can also be marked with a feeling of agitation. It's not always the kind of happy mania that you see in Hollywood movies. And a lot of times when people are manic, they feel like they just want to like jump out of their skin. Like they feel this like incredible agitation and they cannot ground themselves. And it's very difficult. So a lot of times it could be those episodes, and then the body sort of crashes into a depressive episode and it sort of can cycle. And it can be very, very difficult disorder for people to experience.
Okay. Okay. So what are the different types of bipolar mood disorder? Are there any types of it?
Yes. So there is what's known as bipolar 1 disorder, and that's the one that is, I would say, more identified and easier to diagnose. And when I say easier to diagnose, I should note that the average length of time for someone to get adequately diagnosed with bipolar disorder is about 17 years. It can take a long time if you are not, either with, getting mental health treatment, because a lot of times bipolar disorder can look like depression and anxiety when
Yeah.
it's not a unipolar depression, it's a bipolar, depression. And because about half, almost 40 to 50% of people with bipolar disorder abuse substances, sometimes as a way to self-medicate their symptoms. Sometimes it's also hard to tell, is this because they're using drugs and that's why they're acting this way, or are the drugs a symptom of an underlying mood disorder? But bipolar, of the subtypes, bipolar 1 is often easier to diagnose because that's the kind where people have this elated mood for 5 days, maybe they're not sleeping, and then they crash into, these severe depressive episodes. Now, bipolar 2 could be a little bit difficult, where that's more characterized by more depressive episodes and more
Okay.
hypomanic episodes. So bipolar 2 can look like depression, and with an occasional, some elevated sort of agitation. And that can be a little bit harder sometimes to tease apart, because people are like, no, I don't feel this sort of elated mood, but they might feel it in the sense of feeling like really agitated. Or they'll say, patients might say, yeah, it's a hard time to fall asleep because like I just don't feel like in my body, I don't feel grounded. But because it's more characterized by depression, it can be harder sometimes to sort of tease apart. And then there's bipolar disorders that can be sometimes induced by medication or by substances. Sometimes they refer to it as bipolar 3 um, in that way. But now we're sort of understanding in the field that there's this sort of term we use, a bipolar spectrum, that you have like
Okay.
bipolar 1, bipolar 2, but then there's like these kind of mood disorders that are not just depression, but have this sort of what we call like a flavor of bipolar disorder, but someone might not exactly meet the criteria for bipolar 1 or bipolar 2 in the DSM 5, but we know there's some mood instability there. And so they would get diagnosed with like a mood dysregulation, and it's kind of in that spectrum. Like there's a disorder known as intermittent explosive disorder, for example, where it's characterized by people who just can like at a certain trigger just totally be triggered by something and just like rage. And that's like a mood instability. So that person might not necessarily have bipolar disorder, but clearly there's some dysregulation in their mood. We would characterize that in that kind of spectrum, because the medications that help bipolar disorder tend to also help people with intermittent explosive disorder.
Okay. So it can get confusing oftentimes. Like most of the time can get confusing with major depressive disorder. Like
Absolutely.
how patients are reporting to you? Like what are their symptoms? Tell us more about it.
Yeah, so typically when patients come in, it's usually either that they're in the depths of a depressive episode, and because a lot of times I'll have patients that come in who they don't realize they have bipolar disorder. They might say, I'm depressed, which they are depressed, but that might be half of what's going on. And so I'll, assess them, and they'll say, yeah, I'm depressed, and I'll get a history. And then the ones that have a bipolar spectrum, they'll say, well, a month ago, it was the opposite. And I'm like, what do you mean? And they're like, I was just like so full of energy and it was still hard to concentrate. But instead of depression, where I feel like my thoughts were in molasses, they were like going like so fast that I couldn't even catch what I was like thinking. And then it starts to become, more clear that it's more than just depression or more than just anxiety. Sometimes what gets people come to the office is that they might have made a suicide attempt, or they had serious
Okay.
suicidal thoughts that have really concerned them. And I'm glad that they have, seek help. Sometimes they come into my office at the urging of a family member who says, there's something, going on. Sometimes I'll have people come in, they're like, yeah, my mood was just really high, and I was like having, sexual relationships with strangers, and that's not something I normally do. I was shopping and buying these things that I don't understand why I was doing that. Like I felt like I was kind of out of my mind. And psychotic features are also very common with bipolar disorder, namely because if you're not sleeping for 3 to 4 days, your mind does very strange things. I mean, when aren't sleeping correctly. And then sometimes the bipolar disorder gets diagnosed during sobriety when I'm working with someone who has a substance abuse problem. And it is hard sometimes to tease apart because when you're addicted to drugs, it can make you look lots of different ways. And a lot of times with individuals, when they are sober, it's only then that we see, oh, there's like this mood instability, versus sometimes the mood instability could be caused by the drug addiction and alcoholism. At other times, it's people who are really using drugs or alcohol to ground themselves, to numb themselves, to kind of stabilize their mood. Although obviously it's not a healthy way of doing that, but it's understandable why people would gravitate to that when they don't have either knowledge or other resources.
Okay, that's scary. Can you tell us more about bipolar disorder in children? Is it present in children? As you said, it gets time to get diagnosed, like it can even take 17 years of life to get diagnosed.
Yeah, it can be very difficult. So with children, so the short answer is yes, that children can be diagnosed with bipolar disorder. However, it is there's a lot that would have to be taken into consideration for that. So we know that the typical age of onset for most people for bipolar disorder is actually in the mid-20s. Now, it doesn't mean that people might have a depressive episode, like when they're in their teenage years or whatnot. But when there's bipolar disorder, we tend not to see the mania or the hypomania in until like early to mid-20s. And so you might see kind of traits of it earlier on. So now we know that there are a lot of factors, though, that can almost like bring it out earlier. And so one of my big areas of specialty I work with is individuals with ADHD, with attention deficit hyperactivity disorder. And now there are a lot of factors of ADHD that can also look like bipolar disorder. And a lot of times those two can get misdiagnosed with each other. However, people who do have ADHD, about 20% of people with ADHD have depression or bipolar disorder. And studies show that the presence of the ADHD will often lower the age of onset for the bipolar disorder. So instead of 25, we might see it pop out at like 16, 17. Trauma is another one of those things. If a child is experiencing abuse or exposure to traumatic events, then that could bring out the predisposition, because bipolar disorder is something that it's heritable. So typically it's in the genetic tree. That's usually one of the things that I will assess. And my patients who have bipolar disorder or bipolar spectrum often will have a first degree relative, maybe a mom, a dad, an aunt, an uncle, grandparents who are diagnosed with bipolar, or who may not have been diagnosed, but you'll often see it. So for example, this young man that I worked with some years ago, he said, no one in my family has been diagnosed with bipolar disorder. And then the next question I asked is, has anyone in your family died by suicide? Has anyone been involuntarily committed to a psychiatric hospital? And this individual had 5 members of his family and extended families die by suicide. A grandmother, grand aunt, an uncle. And I'm like, that's a pretty good sign that there was probably untreated bipolar disorder in that family. So when we do see it in children, it's usually when there's other stuff also in the mix. Trauma, ADHD, substance abuse, which sometimes, I mean, nowadays you're seeing younger and younger kids engage in the use of substances. However, I always want to preface by there's also a high rate of misdiagnosis of bipolar disorder in children, because you can have children who have very severe ADHD who can look like they have bipolar when it's really they're just severe ADHD, the hyperactivity, the impulsivity, issues of emotional dysregulation, which is very common in folks with ADHD. You can have trauma that is not, it's not bipolar disorder. It's that here's this kid that's in a very traumatic environment, and their mood is, of course, going to fluctuate because they don't feel safety. They could be being harmed. And so we always want to screen for potential post-traumatic stress or just trauma. Sometimes it could be something medical as well, sort of medical conditions that can mimic psychiatric symptoms when in fact maybe they're deficient of a certain vitamin or nutrient. Maybe they have a sleep disorder in which they're not really sleeping, and so their moods are very dysregulated. So there are a lot of things that we want to make sure we're ruling out, and the main reason for that is the psychological treatments could be helpful for anyone at any age, but in terms of the pharmacological treatments, of which medication is essential for people with bipolar disorder. The medications have side effects. They could, they're not easy medications sometimes to contend with, but they're also life-saving. So it's that kind of negotiation. But for children, we want to be aware that some of these medications could be very powerful. And again, if a child actually has bipolar disorder, we want them to get treated. But we want to make sure that it's in fact bipolar and not something else that could be in the mix.
Okay, after hearing all these, I am worrying about children. They might guess they undiagnosed or underdiagnosed. Like chances are really high to that doctors and psychologists might not easily diagnose this problem in children and adults. What do you want to say about this?
Yeah, I think it's a tough thing because bipolar disorder is also, I mean, I would say it's better in the sense of stigma than it used to be, but it's still fairly stigmatized. That I've worked with patients where the diagnosis of bipolar disorder is devastating to them. Like it's almost easier for them to say, I have depression than I have bipolar disorder. So there's still a lot of stigma that I think makes individuals sometimes not likely to report some of the symptoms. I've worked with patients who didn't report that they had racing thoughts that they knew were probably manic because they might have seen it in family members and they were scared. Like, I don't want to have, this disorder. And sometimes clinicians have their biases too, where, sometimes they don't want to see sort of the bipolar disorder piece and hope that it's depression and anxiety rather than bipolar disorder. But and again, we always want to make sure we're screening out, everything else. And the message I want people to walk away with from this conversation is that it's treatable, that if you are getting the proper treatment, you can live a very healthy, productive life with this illness. There are lots of very successful people who have bipolar disorder. And then unfortunately, there are a number of people that aren't getting the proper treatment, or sometimes they're not always treatment compliant, particularly like with medications. Like it's not uncommon sometimes for patients with bipolar disorder to not want to take their medication, and not because they don't want to be well, but because the highs sometimes of the mania feel so good to them, and the medication might almost like even them out in a way that feels bland to them. And I understand that, but then the solution, of course, is not to go off medication, because then that, makes things really hard. And then shame. There's a tremendous amount of shame that people have in having a mental illness and having to take medication for a mental illness. And that shame, unfortunately, has people move away from treatment. And then that's where you start to see a lot of problems. And it should also be noted, bipolar disorder is probably I would say, is the psychiatric disorder that's associated with the highest rates of suicide. That it's a very high, prevalence of suicide. But again, keeping in mind that because, people are being often undertreated or untreated, those are the people who are at the highest risk of suicide. There are lots of people who live full, healthy, productive lives if they're identified, if they're treated, they take their medication, they do the behavioral, psychological strategies, get support, get community. which is so important in living with this with that disorder.
Okay, so I want you to guide my viewers if they are getting diagnosed with bipolar disorder. What are the comorbid disorders which is associated with it, so that they can ask their psychiatrist or psychologist about it? Can you just tell us about it?
Yeah, so typically with bipolar disorder, I mean, we would obviously see the depression and the manic symptoms. It's not uncommon to see ADHD or a history of ADHD, substance abuse. You could have, and it's not just substance abuse, it could be any addictive behavior. So it could be drugs or alcohol, it could be addiction to gambling, to pornography, to food, to you might have individuals who engage in self-harm behaviors like cutting themselves as ways of self-medicating and kind of numbing themselves and grounding themselves. And again, a lot of these things can be could be very shameful for people to talk about. So as providers, we want to ask the questions, you know, are you engaging in self-harm? Are you, you know, binge eating? Have you ever had issues with sexually impulsive kind of behaviors? So a lot of times those are the disorders, and anxiety. So a lot of times what they feel as anxiety might actually be more mania and hypomania. So we always want to be on the lookout. A generalized anxiety disorder, which is sort of the worry disorder, is common, you know, in people with bipolar disorder. And then you can sometimes see psychotic features too, people hearing voices when they're very manic, seeing things, and that could also really scare them. But we need to ask the questions as providers, and in a way that's non-judgmental, and, you know, just to sort of say this is common in what we would see, you know, with this population. But those are sometimes, because I'll work with individuals, let's say, who are diagnosed with ADHD, and I'm doing work with them, and it's clear to me that there's something more than ADHD happening here. And then I'll assess, and it turns out that there may be some bipolar disorder. And then I've also worked with people who are diagnosed with bipolar disorder, and as I mentioned before, they don't have bipolar disorder, they have ADHD, because it can sometimes look very similar.
Okay. Thank you for sharing all these with us. Can you just tell us, how do you treat your patients? What are the treatments of it?
So I'm a psychologist, so I don't prescribe. I don't have authority, and I don't have interest in prescribing medication. I leave that for the psychiatrists and psychopharmacologists to do. But medication is an essential part of the treatment. That bipolar disorder requires some pharmacological intervention to stabilize sort of the neurochemicals, you know, in the brain, and having somebody, and sometimes it's finding the right medication at the right dosage. It can be a process sometimes to get, you know, and find that regimen that's going to work. Now, the work I do as a psychologist is more the sort of psychological work. So one is identifying triggers that people might have. So we know that sleep hygiene is incredibly important for people with bipolar disorder. If they're getting 3 hours of sleep a night, that is putting them at higher risk for developing a manic or depressive episode. Working on sobriety, we know that the engagement of substance use increases their risk of depressive or manic episodes. So looking at what in managing stress, I do a lot of stress management work, and we want to bring down the stress, because stress can trigger manic and depressive episodes. So stress management skills, sleep hygiene, eating, physical activity, because all those things are really important to discharge stress. And then there's also work just around even their concept of themselves. Unfortunately, for a lot of people, because they have this illness, they think badly of themselves, like, oh, I'm not, like, who's going to want to marry me because I have this illness? And so a lot of the work is also around self-esteem therapies, and working on, no, you have worth and you have value. Any, you know, this is almost like, almost looking at it in the same way we would look at it you had a history of kidney stones. You know, it's just this medical thing. This isn't a lack of willpower. This isn't about weakness. This isn't any of that. Psychiatric disorders and illnesses are medical. They're medically based. And so we definitely want to put it in that frame. And so just like if you had, migraine headaches, you take a medication that can help with the migraine headaches. This is no different in my book. So self-esteem work, and then something called cognitive behavioral therapy, which looks at one's cognitions and targeting negative self-talk that people might have, and making it not even so much, I mean, ideally we want it to be positive, but really making it accurate. So if somebody has a thought of oh, no one will like me, it's like, well, no, that's not true. I mean, but I wouldn't say everyone will like you, because there isn't one person on the planet where everyone will like them. So we want to make it accurate. Then the behavioral part of CBT would be those things I was talking about, like what are the behaviors, the routines, the structure, how we set our day. And then DBT, which stands for dialectical behavior therapy, is a wonderful treatment model that was originally designed for people with borderline personality disorder and who engage in self-harm behaviors, but has since been applicable to virtually everything, because DBT is a very skills-based therapy that focuses on emotional regulation skills, interpersonal situation skills, distress tolerance, and mindfulness. And all of us can benefit from those. So those skills are very important. And what happens when you do get stressed? How do we deal with situations in which we might be angry? Because it's all about basically stabilizing our moods and our stress, and to be mindful and in the moment. So it's kind of an integration of all of those things. But I would say if medication is not in the mix, it's none of it's going to work, because the mind is not, it's not enough if someone is unmedicated to be able to even grasp some of those things, because it's just any more than if I told you, like, if you had a splitting migraine headache, I don't have migraines, but I know I have friends who do, who when they're in a bad migraine, they have to shut all the lights off. They can't, it's like any sensory stimuli is so strong for them, they can't even think straight. And so that's what happens. Like, it's almost like if you're not on the proper medication, it's like you're not even, it's not helping. And then where if suicidality is in the mix for that individual, for some people with bipolar, they don't have any suicidal thoughts, but knowing that it's a psychiatric disorder that's associated with the highest risk of suicide, recognizing what are the what we call red flags of when you're starting to think down that road, so we can catch it like immediately, as opposed to getting deep kind of into those thoughts. And to be able to share that, because even with suicidal thoughts, there's a lot of shame that people have in disclosing, even to their mental health provider, like, I'm having these thoughts. And we as providers want to normalize, to say there's no shame in having that. And we clearly want to pay attention to them, because it's very, very important to that, but not for the person to have any shame around having those thoughts.
Okay, thank you so much for sharing everything with us. I'm sure this is going to benefit our viewers a lot. And I want all my viewers to reach out to Dr. Roberto and know more about his work. And if you want to ask anything about your mental health, your child's mental health, do contact him. I'll be putting his email address in the description box along with his website, so that it will be easy for you to go and contact him. Thank you so much, Dr. Roberto, for being here with us.
My pleasure. Have a good day.